Hi everybody, I'm preparing another resource to go along with the lectures I already have posted in this module to help you better understand how information that we process or we collect within the transfusion service is used to help us work through an antibody identification case. I know this is something that is difficult to do if you have not worked in a transfusion service or done any kind of clinical rotations within a blood bank. So this is an extra resource to help you see how we critically think and use information to solve antibody identification cases. And this presentation will match your homework so that it can help you work through a problem if you've never seen anything like this before. So let's go ahead and move on to the next slide and get started. All right, so we have our case history here. We have a patient, 57-year-old male. He's having a knee replacement surgery. 2 years ago, he had his first knee replacement surgery and he had complications. So he ended up with a transfusion of 2 units post-operatively. So that's one clue that this patient has had some kind of potential antigen stimulus in the past. So it's plausible that he could have an antibody present. The transfusions themselves were unremarkable, and we now have a current order for a type and cross match of 2 red cell units in preparation for his next surgery. So let's move to the next slide. The ABO and Rh typing is presented here, and it's shown both as the forward typing and the reverse typing. So our forward typing shows that he has a strong reaction with anti-A. Now remember again, the forward cell typing is done on the patient cells. So this reaction with anti-A says that he has A antigen present on his cells. He also has D antigen present on his cells. The reverse typing is done on patient serum using reagent back-typing cells, and this shows us that he has no reactivity when we use his serum with A1 cells, and we have 4+ reactivity when we use his serum with reagent cells that have B antigen. So his forward cell typing shows us that he has both A and D antigen present, so he types as A positive in the forward type, and his reverse typing shows us that he has an antibody to the B antigen, or he has anti-B present. So the forward cell typing and the reverse cell typing match. It shows us that he's A positive and there's no discrepancy present. So it's important for us to note that there's no discrepancy present. This tells us that the likelihood of him having a cold alloantibody or autoantibody that would interfere in additional testing is unlikely. And so if we have an antibody problem that we need to worry about or work through, at least we don't have a cold interference. So let's move on to the next part of the type-in screen, and here we have his antibody screen. So this transfusion service uses a 2-cell screen, which shows limited information, but we can still get some good information from this initial screen. And so if you're following along with in your textbook, we can apply some of the guidelines for an interpretation of a panel actually to the antibody screen. So on the screen, typically most transfusion services don't do an auto control, so we don't have that information present for us, but we can see here that we do have a positive reaction. So we have a positive antibody screen, and what information we can find out is the phase of reactivity is noted here. So this transfusion service uses the gel procedure, and so the gel is read only at one phase. It's read at AHG phase. So that tells us that we're very likely working with an antibody that's an IgG specificity. So this is an unexpected antibody that is most likely going to be clinically significant. It's something that we do need to identify so that we can help provide blood that's negative for the corresponding antigen. Although there is no autocontrol that's been performed, we do see that we have a negative reaction here, And also the ABO typing that we did previously, if you remember, I pointed out that we did have a negative reaction in the forward type and we had a negative reaction in the back type. So the likelihood of us having a cold antibody that would be interfering with the testing is unlikely. So even though we haven't done an autocontrol and we also don't have a DAT at this point, the likelihood of this patient cells being coated with some kind of globulin is again low in this case. So things that we can look at and we can discern from this antibody screen are that we do have an unexpected antibody. It's an IgG class antibody. And now we can look at the pattern of reactivity. So the pattern of reactivity here shows us that we have one positive and we have one negative. So things that we need to worry about or be concerned in terms of the pattern of reactivity are we dealing with an autoantibody? Are we dealing with an alloantibody? Are we dealing with multiple alloantibodies? So we do have, again, limited information, but we can at this point presumptively rule out an autoantibody for the reasons that I explained before. We do have a negative reaction, and most of the time when you have an autoantibody present, that's going to cause you to have pan-agglutination reactivity or antibody with all screen and panel cells. Multiple antibodies will show reactivity of varying strengths. Very often it will show reactivity in more than one cell, and even though we have only a 2-cell screen here, which provides us with limited information, right now what's pointing to what this reactivity that is shown is pointing us toward is this is most likely a single alloantibody specificity. Because of the reactivity, the strength of the reactivity is low, it's 1+, and also we have reactivity just in one screen cell. So while we don't have all the answers yet, that kind of directs our next steps in our identification. So at this point, I would not do a DAT. If it's protocol to do an auto control on the panel, that's good enough at this point. I'm not expecting that auto control to be positive. And if I was working in a transfusion service, what I would do now is I would set up the panel and get that incubating. And while the panel's incubating, I would go ahead and go through and do a presumptive rule out or a preliminary rule out, because I do have one negatively reacting screen cell here. I would go ahead and go through and do an initial rule out. So remember, when you do rule outs, you rule out only on double dose cells unless you are told otherwise, unless you are given instructions otherwise. So if we go through and we do our preliminary rule outs, remember the plus means that antigen is present on that reagent cell, and negative means that antigen is absent. And here's where you do have to put your blood group system knowledge to use. So remember, big D does not have an antithetical antigen, so if it's present on a cell, we can go ahead and cross that one out. And I like to use double crosses if I'm crossing out on a double dose cell versus a single dose cell. That's just an old habit that I've used. So now if we move over and we continue on in the RH system, big C is absent on this reagent cell, and but big E is present. Now big E's antithetical partner is little e, so I presume that this is a double dose of big E on this panel cell or this screen cell, so I'm going to cross that out. And as we noted before, big C is absent and its antithetical partner is little c, so I can rule this one out. Moving on over, M and N are antithetical pairs, so M is present in double dose, so I'm going to cross that out. Our next antigen that is present is little s, its partner is big S, so because it's present in double dose, I can cross it out. In the Lutheran, I only have Lutheran B present. Lutheran A and Lutheran B are antithetical partners. So because this screen cell is negative, I can rule that out. P1 doesn't have a partner, so like D, if it's present on a non-reactive cell, I can rule it out. Lewis A and Lewis B are not antithetical partners, but Lewis B is present on this cell that's non-reactive, so I can rule it out. Big K, little k, those are partners. Little k is the only one that's present, so I can rule it out. We move to Duffy's. This is a heterozygous cell, so I cannot rule out either Duffy. And JKA and JKB in the kid system, that's an antithetical relationship there. JKA is the only one that's present, so I can rule it out. So now what I have is kind of a list of things that have not been ruled out at this point. I haven't ruled out anti-big C, anti-little e, anti-F, N, big S, Lutheran A, Lewis A, big K, either Duffy or JKB. So I kind of have an idea of what my potential antibody specificity will be. Now I'm going to wait for my panel. That's forthcoming. So let's move on to the next slide. So the summary of the case thus far while I'm sitting and waiting for incubating. And this is a good idea to always kind of put together a summary, because you never know when you're going to get a phone call. Like the physician may call or the surgeon may call and say, what's going on with the patient? Do we have blood that's present? And what you could tell the physician at this point is the patient types is A positive. There were no discrepancies noted. We do have a positive antibody screen. It's an IgG antibody. It's probably a single allo antibody, but we are waiting for further identification. And it is plausible that this patient does have an antibody present. He did have a stimulating event in the past. He received 2 units of red cells 2 years ago with a previous surgery. So that's good information to present to a physician, nurse, whoever might be calling and wants information on where we are with the workup. This is a pre-op, so the likelihood of somebody calling is low because hopefully surgery is scheduled for tomorrow, but that's not always the case. But this is also a nice summary for us to move forward and continue our investigation. So I have a question here. Which of the following antibody specificities is most likely based on the results of the antibody screening and the patient typing results thus far? So again, we're waiting for our incubation here. We can think through some things, and we did do a preliminary rule out on an earlier slide, and we can bounce back to that in a minute. But we can answer some questions so far. So anti-D, is that plausible for this patient? And the answer for that would be no, because this patient typed as A positive. So it's very unlikely for a patient who has the D antigen to make an antibody against that antigen. There are cases where a patient may have a partial D and can make an anti-D, but right now we would not suspect that. Anti-big K. Again, we said we did the preliminary rule outs, but let's say we didn't want to mark up our screen and we didn't do those preliminary rule outs. We can just do an initial rule out here. So again, we can only do rule outs on negatively reacting cells. So let's see, can we rule out our anti-big K at this point? Well, we have a negatively, or this panel or screen cell number 2 does not have the big K antigen present, so we can't rule out anti-big K. That is plausible. Anti-M, did we rule that one out? Sure enough, we did. Look, it's present in a double dose on this cell, so that was one that we did rule out. So anti-M is not plausible. How about anti-Lutheran A? Well, if we look at our screen cell number 2, again, this was negatively reacting, and Lutheran A is not present, but it's also not present here. Remember, Lutheran A is a low prevalence antigen in the Lutheran system. So the likelihood of this specificity being anti-Lutheran A is low because we had reactivity on panel cell 1, even though Lutheran A is negative, but we also had a negative reaction on screening cell 2 when Lutheran A was not present. So of this list, the most likely antibody at this point is anti-big K because we have not ruled it out. But remember, on our earlier preliminary rule outs, there were other specificities that we also had not ruled out. All right, so our panel results are up at this point, and we can see that again, our panel is done in the gel methodology. So that means that we have one phase of reading that's done at AHG phase. So again, that tells us that the antibody specificity that we're working with is an IgG specificity. Our antibody screen showed 1+ reactivity in one of the screening cells, and we see we have reactivity in 4 of our panel cells. So that means we have a nice number of negative cells that will allow us to do some ruling out. We also did do an autocontrol here. Our autocontrol was negative, so based on our analysis of our screen, we had made an initial hypothesis that we were not dealing with an autocontrol, and the testing that we did on the panel shows that the likelihood of this being an autoantibody is very low because the autocontrol was negative. So the next thing that we do is we're looking at the reaction strength, and we have multiple cells. We have 4 cells that are reacting at 1+. So our earlier hypothesis that we were dealing with a single alloantibody specificity is carried through to the panel because we have our pattern of reactivity shows the same reaction strength on all of the cells that are reacting. So the next thing that we need to do is start our ruling out. Now remember, we did a presumptive rule out or an initial rule out on our screen. We were just killing time. But now we can go through, we have more panel cells, and this will give us a better idea of what we have and have not ruled out. Now I have our protocol listed here for antibody identification, and the antibodies that must be ruled out or in using cells with double dose of antigen are listed here. So things to note. Big K can be ruled out with a heterozygous cell, and also Lutherans, and we know Lewis does not have any antithetical relationship. We do have Lewis A and Lewis B, but what that means, if the antigen is present on those cells, it's just present. There's no dosage. So let's go ahead and do our rule outs. That's the next step in interpreting a pattern. So let's start with panel cell 3 is our first negatively reacting cell. So we'll go through, and we'll do this a little quicker because I talked through how to interpret the presence of the antigen on the antibody screen. So we'll rule out D and big E, little c. F is not present in this case. We have a homozygous expression of N here. I cannot rule out either anti-big S or anti-little s because of the heterozygous expression of both antigens. Lutheran B I can rule out. Little k. Can't rule out either Duffy, heterozygous here, and JKB. Our next negatively reacting cell is cell number 4. So I can rule out D again here, and I do rule out each panel cell independently or individually. That's just how I was taught, and that's how I do it. So we have double dose here, and F does not have an antithetical allele, so if it's present, we just cross it out. Can't cross out M or N here, but I can rule out anti-little s, Lutheran B. P1 does not have an antithetical partner. Lewis A is present here, so I'm going to rule that one out. Little k, JKB. Next negatively reacting cell is cell number 6. Big E, I cannot rule this one out because both big E and little e are present. So I have a single dose expression here, so I can't rule out either one of those, but I can rule out little c. Can rule out F. M and N are present, so this is heterozygous across the board for M and S. Lutheran B, P1, Lewis B, little k. I can rule out Duffy B here, but I can't rule out either KID antigen because of the heterozygous expression. So now I'm going to just kind of rule these guys all out together. Now that we've done individual, I'm going to look at these 4 cells all together just to show you another way how you can move across. So I'm looking at these 4 cells together. All right, so look here, I can rule out anti-little c on all 4 cells and anti-little e on all 4 cells. So here's the interesting thing that you can discern from these. Most panels do have a section of D negative cells that are probably all little r genotype. So that can help you rule out if you have an anti-D specificity that's present when you're working on another patient. The panels do try to construct an RH negative or a D negative section for you. F we can rule out there. Now let's look at these individually. So MN, MN, these are all single specificity here, but here I do have cell number 9 is homozygous for M, and cell number 10 is homozygous for N. I can rule those out. Now let's look at our S's. I can rule out anti-big S here and anti-little s here. Lutheran A, negative across the board. That's not atypical on most panels. Again, Lutheran A, this is a low prevalence antigen, and so typically most panels that are constructed are Lutheran A negative. So, but what that means is Lutheran B, I think I may have said Lewis earlier. I apologize. This is Lutheran and P1 Lewis. So Lutheran A is a low incidence or low prevalence antigen. Lutheran B is high prevalence, so we've got that one ruled out. P1, cross these out. And again, I'm just showing you this is a different way to do it because there's no one way to do this, I guess is the best way to put it. The one thing that you do want to do is you only rule out on negatively reacting cells, but the pattern of how you do that ruling out is kind of up to you. So, and when we get to the Lewis's, no antithetical partner, so if it's present in a negatively reacting cell, we can cross it out. Big K, all right, this one here is a single heterozygous for both specificities. And down here, if we look at our laboratory protocol, it does say that we can rule out anti-big K and anti-little k for that matter with a heterozygous expression. So I can rule both of these out. And if I do rule something out with a heterozygous expression, I do a single cross. And that's just a visual for me to remind me hey, it's ruled out, but you ruled it out on a heterozygous cell. But I do have enough homozygous cells here for little k. I've ruled it out. All right, when we get to the Duffys, Duffy B, Duffy A, and Duffy B, and Duffy A. Nice little pattern there. Our kids, all right, at this point we have JKB ruled out. Here's a homozygous JKA and a homozygous JKB. So now I have done all of my rule outs on all of my negatively reacting cells, and I like to make a little summary up top here. So everything that I've ruled out down below, I come up and I show how did I rule it out. This is just a quick visual for me. And again, different transfusion services will have different protocols on how they rule things out. This is how I was taught, and this is how I do it. If somebody is at your clinical site or your transfusion service does it a little bit differently than me, that is okay, as long as you follow the procedure that's at your institution. But I am kind of a type A personality, and I like all my I's dotted and my T's crossed. So now if I look here at the top, the only specificities that I have not ruled out are anti-big C and anti-Lutheran A. So my next step in the guideline for interpreting a panel is to match the pattern of reactivity. So I'm going to change to a highlighter here. I have 4 cells that are reactive, and if I match with my first specificity that has not been ruled out, every time I have a positive reaction, look, I have that antigen present. I also did not rule out anti-Lutherin A, but it does not match the pattern of reactivity. Again, as we discussed, this is a low incidence antigen. I don't have any panel cells that are positive for this antigen, so the likelihood of this one being the cause for the reactivity I'm seeing is very, very low. Now, am I going to work to try to rule this one out? No, I am not. That's what the cross match is for, and that's for another lecture. But I will not do any additional work to rule out the anti-Lutherin A specificity. If I follow my rule of 3, which is the next step in the guideline for interpreting the panel, I do have three big C positive cells that are reactive. 1, 2, 5, and 11. I actually have 4 cells, and I do have 3 big C negative cells that are non-reactive, and in fact I have more than 3 here. So I have met my rule of 3. So let's move to the next slide because I do have some additional questions for you. I'm going to go back to my pen here before I move to the next slide. All right, so I have a question. Which specificity is most likely? So I did all my rule outs on the previous screen, and I've now moved past them. So I'm going to show you, again, a quick way just to answer the question. So is anti-big K, is that a likely specificity? Well, let's quick look over here at our panel. I have 2 panel cells that are positive for the big K antigen. Again, if because it's big K, it can be a heterozygous specificity. I do have 1 panel cell that's reacting when big K is present, but I also have 1 panel cell that's negatively reacting when big K is present. So I could actually rule big K out based on this negatively reacting cell. So anti-big K is not a possibility. Anti-Lewis A, let's do the same thing. Let's find, oh look, right there. That 1 negatively reacting cell also got rid of anti-Lewis A. Well, anti-big K we know is not a possibility because we ruled that out here, but what about anti-big E? Could that be causing? And let's look here. Here's a negatively reacting cell that is positive, double dose in strength for anti-big E. So, as we noted on our previous rule out panel, anti-big C is the most likely specificity, and in fact that matched the pattern of reactivity. So we've ruled out all of these other ones as improbable, and we have additional information that anti-big C is the best answer for this question. Here's another one. Which panel cell is most appropriate to rule out anti-M? So now remember, anti-M has an antithetical partner, N. So if we want to rule out anti-M, it needs to be on a negatively reacting cell that has a double dose or homozygous expression of M. So we have panel cell 3, 4, and all of this whole section here that's all negative. So cell 1, we can't use that because it's a positively reacting cell. We cannot rule out specificities on a reagent cell that's reacting, so we can get rid of that. Cell number 3, how about that one? That's a negatively reacting cell, but M is not present, so we can't use that one. Cell number 7, that's in this set here of negatively reacting cells. Cell number 7, look here, and we have M that has heterozygous expression, so we can't use that. Our last cell number 9 is non-reactive, and it's also homozygous for M. So cell number 9 is most appropriate to rule out anti-M. Another question, using both the antibody screen and the antibody panel, which specificity is not ruled out? Now this is one thing that people often forget. You can use the cells from the screen along with the panel to help you rule out specificities that may not have been ruled out on either the screen or the panel. Remember, the panel is just an extension of your antibody screen. There's just more cells present on the panel. So if we think back and we remember, we just answered this question on a previous question slide. Anti-big K, that one's ruled out, and we can show here right there. This guy ruled out anti-big K. Anti-Duffy A, did we rule that one out? We sure did. There's one right there. Actually, there's a couple rule outs. And anti-big S, did we rule that one out? That one we got down to the wire, but we did have, I thought, a specificity. Yep, here we go. Anti-big S is present in homozygous expression there, and the cell number 7 was negatively reacting. So we got rid of all 3 specificities. Now, another question that we touched on earlier, if this lab had a 3+3 rule, would we need to run any additional cells? Well, we did identify that anti-big C is the causative antibody in this case. And we noted that we had, here's 2 cells, 3, 4. We had 4 positively reacting panel cells here that are all homozygous in strength, and we have more than 3 negatively reacting cells that are also big C negative. And if we include the screen in this as well, we have even more cells. So our 3+3 rule is more than satisfied in the case of this antibody. All right, phenotype the patient cells. This is one thing now. So we're cruising along, we've worked through our screen, we've worked through our panel, and now we have to think opposite. So we have identified and we've met our rule of 3 that shows that the specificity that's present in this patient's plasma is anti-big C. But now we have to show that this patient has the capability of making that antibody. And how do we do that? So if we've identified an antibody in the patient's plasma, we need to ensure the patient can make that antibody. And we do that by performing a phenotype on the patient's cells. Remember, if we think back to immunology, a patient who how we make an antibody is we make an antibody to something that's not like us. So in order for this patient to have made anti-big C, that means that he must lack the big C antigen on his own cells, because remember, we had a past transfusion stimulus for this patient, so it was very likely that he through transfusion he was exposed to the big C antigen and he made an antibody against it. But now we have to show that this patient himself lacks the big C antigen, and we do that by performing a phenotype on his cells. We found the antibody in his plasma. Now we need to show the presence or absence of the big C antigen on his cells. So our recipe here is we use the patient's cells plus a reagent antibody. So in this case we need to use a commercial anti-big C antisera to test the patient's cells. Now make sure that when you're performing a phenotype or you're doing antigen typing on the patient's cells, look at the package insert to see what procedure you need to follow to complete the phenotype. In the case of an RH phenotype, big C is in the RH system. Most of those, and not all, but most of that antisera is monoclonal in nature, and so it can be done at media spin phase. But be sure that you read the package insert that corresponds to your specific antisera. So again, we want to show the patient is negative for the antigen that corresponds with the antibody that we identified. The other thing that we want to do is we want to remember to check the transfusion history. Most transfusion services do not like to perform antigen typing on a patient who's been transfused in the last 3 months because of the presence of a dual cell population, and you'll likely get unclear results if you do an antigen typing. So in the case of this patient, if you think back to the transfusion history, he was last transfused 2 years ago, so well outside the window. We could perform a phenotype on this patient's cells. And in this case, we would expect this patient to be negative for the big C antigen. All right, so interpreting the antibody workups. Again, if we put all of this information together, we can see how this helps us come up with an answer that we can put in the patient's chart. So we used information from the ABO typing results, not only to show what type this patient was, but for us to determine, without performing a DIT, whether or not it was probable for this patient to have a complex antibody ID or just a regular workup. And because we did see negative reactivity in the patient's ABO type that was appropriate, that showed us that we most likely didn't have any kind of cold alloantibody or cold autoantibody interference. The antibody screen gave us some initial clues to the complexity of this problem. Again, without doing the rule outs on this patient, what we saw was our phase of reactivity was IgG, so that meant it was a clinically significant unexpected antibody. The reaction strength was 1+, and we only had one positively reacting screen cell, so that kind of gave us some initial information that we were most likely dealing with a single alloantibody problem as opposed to a multiple alloantibody problem or an autoantibody. The reaction pattern, again, that showed us the 1+ reactivity, showed us, you would expect with multiple antibodies. Say, for example, this patient had antibodies to two specificities that were only present on one panel cell. You would expect the strength to be a little bit stronger, say in the 2+, even up to a 4+, for us to start thinking, maybe we have multiple alloantibodies. And we also were able to perform some preliminary rule outs that did feed into our antibody panel, although our antibody panel was pretty straightforward because we had a lot of negatively reacting cells. So the antibody panel is where we are able to work through our guidelines for interpretation of a panel and complete all of these steps. So the antibody panel, again, we were using the gel methodology, so we only had one phase of reactivity that we could look at, but that showed us, again, we were dealing with an IgG antibody. The reaction strength carried forward from the screen to the panel, so again, that gave us more information. Hey, this is most likely a single alloantibody. We were able to perform ruling out, and we were able to rule out everything but our causative antibody and anti-Lutherin A. Remember, Lutherin A is a low incidence antigen in the Lutherin system, and it's very, very unlikely for it to be present on a panel, but that's why we do a complete cross-match, and that is more information about cross-matching is in a different lecture, so we'll talk about that later. We were able to match the pattern every time we had a reactive panel cell and screening cell. If we look back on the screen, the big C antigen was present. We were very easily able to meet our rule of 3. We had at least 3 big C positive cells that were positively reacting. We had 3 big C negative cells that were negatively reacting, so we met our rule of 3, and then we explained the purpose and how we perform the patient phenotype. I didn't show you the results, but we would expect in this case the patient to be negative for the antigen that corresponds to the antibody we identified. So I hope this helped you work through how we put all of this information together. I hope it helps you understand your homework a little bit better, and please be sure to let me know if you have any questions about anything. Happy antibody IDing, everybody. Take care.